I will now turn things over to Cheryl Harrison, our President and Chief Executive Officer, to begin the community chat. Cheryl?
Thank you so much, Tracy. Next slide. Welcome, everybody. So we're going to start with our land acknowledgement tonight. We, Muskoka Algonquin Healthcare, acknowledge that we are situated on the traditional territory of the Anishinaabe. We wish to deepen our understanding of the culture of the local Indigenous communities to develop appropriate culturally safe health services by building trust through respectful relationships that are acknowledged past harms and mistakes to move forward in the spirit of truth and reconciliation based on the 7 grandfather teachings. Miigwech. Next slide. Thank you. So before we get started, I just wanted to do some introductions of the panelists that we have with you tonight with a little bit of their background, and it might help you as well in terms of where you may want to ask some questions. So I'm going to begin with Mary Silverthorne. Mary is our Associate VP of People and Chief Human Resource Officer. She's a certified human resource professional with over 34 years in Ontario public service. Her last 23 years has been with the OPP, and she also has previous hospital leadership, including at Muskoka Algonquin Healthcare. Dr. Khalid Abdurazik, our Chief of Staff at Muskoka Algonquin Healthcare for the past 5 years. Khalid is an obstetrician and gynecologist with over 35 years experience. 20 of those years have been with the North Simcoe Muskoka region, and he has over 13 years of physician leadership experience. Alistair Smith is our Vice President of Corporate Services with 35 years in healthcare. He's also the executive sponsor for our redevelopment project, and he brings a lot of experience with large hospital redevelopment projects like ours. Melissa Bilodeau is our Chief Nursing Exec with 19 years of experience as a registered nurse here at Muskoka Algonquin Healthcare, and predominantly Melissa's background is in ICU. Tim Miller is our Director of Facilities, and he's our Capital Redevelopment Project Manager. He's an engineer by background, and he has been with MAC for 7 years. I always introduce him as the man you need to ask about why we need to redevelop these aging infrastructures. Tim has all of the information that you would ever want to know about them. I'd also like to introduce Marta Long. She's the project support for the redevelopment project. Tammy Tkachuk is our executive assistant and board liaison for 20 years, and she has been through every stage of this redevelopment, as many other people have been, but she certainly is our go-to historian for many questions that we have. I'm Cheryl Harrison, the President and CEO of Muskoka Algonquin Healthcare. I bring over 40 years as a registered nurse. My clinical background is emergency, as well as having extensive leadership in communities similar to the size of Muskoka. I'd like to also introduce a couple of panelists that are with us tonight. Katie Zammit. Katie is the Manager of Women and Children and Transitional Care. Lindsay Bishop is our Manager of Surgical Services, and Yazir is our Director of Quality, Risk, and Patient Experience. And I'm sure that any of them will be happy to answer any specific questions on their areas. So finally, I'll turn it over. Maureen Miller is our board chair, has been for 9 years. She's also been the chair of our local share committee, and that you're going to hear a little bit of an update on tonight. But thank you, Maureen, and thank you to all the board members that you're just going to introduce now.
Cheryl, I'll just jump in quickly as Maureen rejoins. She was having some technical difficulties with her screen freezing.
Okay. When technology works, it really works, eh?
She does assure me she's signing right back in.
Dave, do you want to maybe introduce yourself and acknowledge any board members
I
that are
can
with us tonight?
introduce myself, but unfortunately I don't have a list of the board members who are in attendance. So I'm Dave Uffelman and I am vice chair of the board.
Thanks, Dave. Maureen is just about there.
So sorry, I'm assuming that Dave covered for me. Welcome, everyone. Dave, did you introduce the other board members?
I didn't have the list, so
Okay.
I only introduced myself.
Okay, great. Sorry about that. One of the challenges that has been brought up is our healthcare or our internet service here in Muskoka sometimes doesn't work. I apologize for that. Joining Dave and I on the call today are other board members, Bill Evans, Dr. Bill Evans, Carla Clarkson-Ladd, Mary Line, Lynn Villeneuve, Anna Landry, and Colleen Nisbet. They're all on the line with us today. So thank you to the board members for attending tonight. Over to you, Cheryl.
Thank you, Maureen. Next slide. So I'm going to start off, and I'm with the fact that we are doing more than just building 2 new acute care hospitals for Muskoka. It's definitely exciting, and we're really very looking forward to it. However, it's more than that, and we've been given an opportunity to build more than that. Knowing what our healthcare system looks like today and what it could look like in the future is very different. And so we want to take this opportunity that to build those 2 acute care hospitals as part of our hospital system. But we also want to take the opportunity to ensure that we're expanding services where we can bring in new services, services we don't have today that we know in 10, 15, 20 years in the future we will want to be providing to our region. We also want to really make sure that we're building a model that will attract and sustain our human resource needs today and into the future. And then finally, we want to really take the opportunity as we build this, these 2 hospitals to ensure we're getting the best out of what the future healthcare is related to in terms of community care. And that is the way of the future. 10 years ago, we were doing things in hospitals that we're not doing, that we're doing now in the community. And we're fortunate, even in Muskoka, we've been able to be very innovative in some of those things. But the art of the possible, moving away from things in the that need to be in the hospital versus in the community, is the absolute way forward in our healthcare system of the future. As I said, healthcare has changed, and it's certainly changed since we built these new hospitals 50, 60 years ago. Just take a look at inpatient surgeries that we were doing 10 years ago that now are done on the same day and go home the same day. We're pushing, as I said, we're pushing care into the community more so than ever, and not because we don't want to do it in hospital, but because it improves access when we can have certain services that are appropriate in our community. Our hospitals are about care and service and go well beyond the number of beds. Next slide. Thank you. Wanted to just really, for those that don't know the area that Muskoka Algonquin serves, it's more than just the district of Muskoka, and it's certainly more than just full-time residents that live here. We cover 4,000 plus square kilometers that we need to service. There's the breakdown there of how many Muskoka residents we have. Up to the north, we service Almaguin residents. And then, of course, we all know that there's an additional, on top of this, the data that you see here, another 80,000 plus seasonal residents and 3.2 million visitors that come through our area. And interesting statistic is that a million of those 3.2 million go through Algonquin Park. So just wanted to kind of set the stage to the area that we do service. Next slide. So I want to take a few minutes on this slide because we have been on this planning journey for a number of years, at least 10, if not more. And want to start with 2015. There was the one hospital that was proposed for many reasons. Over 2 years, that model was redirected in 2017. So we have 2 years, a delay right there, just in terms of not accepting that model, needing to look at another model. And so we were directed to explore a two-sided model in 2015. There was also during 2017 and 19, a lot of discussion about whether we could renovate our existing sites. And we currently get asked that a lot even still. Our facilities and others really try to make our both sites look as best as possible, but there's a lot of things that renovation would be required to do that we couldn't afford and is too disruptive to care. And there's many hospitals experience that have discussed this disruption to care. So in last year, between February and September, we started the piece of the submission, which is called functional programming. And it was based on looking at 2 sites, status quo in terms of our operations, and start to work those up. It was a lot of work that these groups had done. And we already knew going into the functional programming with the user groups that there were many areas of deficits that we had in the current status quo. And so we tried to take a look and push ourselves to see if we could course correct on some of those. And there may have been, I would say, some development on that, but largely what came out was that we were going with the 2-site status quo. In September, as part of the process, when you're doing a project this size, and the fact that we knew from Infrastructure Ontario and the Capital Branch that costs were escalating in terms of construction, we did a cost estimate process and found out that in September, the cost to build this model would be close to 50% over the budget. Excuse me. Very quickly, we took a look and said, okay, is there any way that we can build the 2 sites status quo and just reduce the footprint, something as straightforward as that. It didn't take long, to be honest with you, to find out that that model would also not be viable. We would have to reduce services to an unacceptable level, and it wouldn't be efficient or affordable either. So on October the 12th, we notified Capital Branch, Ontario Health, Infrastructure Ontario, the team we've been working with every month on this project as we've been moving along, and discussed what options we might have. Their message to us was clear. There is no more money to add to build to that extent, being 50% over the budget, remembering that the project itself is about $967 million, just shy of $1 billion. And they really urged us to explore different models. The comment was, you know, in some organizations that are only trying to redevelop one site, they don't have a lot of options. Could we look at ways of reducing duplication because we have an organization with 2 campuses? We also heard from them that we aren't alone. Every hospital redevelopment project is coming in anywhere between 50 and 60% higher than expected. Cost estimates, you know, also were significant, and we wanted to go back and take a look once we did the redevelopment to see whether or not we would be able to reduce the amount. So we came up with the new a different model concept. We went out to the user groups for exploration. So again, apologize for the quick turnaround, but we wanted to make sure we could make the best of our timelines. So in November, we had user groups going back and forth right through till January. Happy to say that the new cost estimates are significantly reduced. And what's really important as well is the local share component that I'll explain for those that don't know about it. That envelope of $225 million that our communities have to raise was unchanged with this new model. And again, I just want to acknowledge that I know a lot of this seems like it's, come out of left field. We have been working really hard and wanting to keep this project on track and reduce the risk of it going off track. So we worked with the groups and they've given us a lot of feedback. Next slide, Allison, please. Our process for planning throughout this whole period and including up to the last 3 or 4 user groups was to about 250 people. There were staff, physicians, volunteers, hospital leaders, other folks we work with in the healthcare partnership area. We had our consultants who, again, are building hospitals all across the country, really providing us with up-to-date best practices for the future. And we also had community engagement sessions in January. And although those were focused on our local share and site selection, we also had a great opportunity to talk to many people about what they wanted to see in their healthcare system of the future. I want to reinforce that this process has been very intricate. It has brought lots of people to the table. And I want to acknowledge that there's still people that don't feel as though they maybe were as engaged as they wanted to be. And we're continuing with that process. Next slide. So based on what we've heard from the community sessions and other folks that we've been talking to, happy to see that this new model will be able to provide new and expanded services. We'll improve the care by concentrating patient services, which you're going to learn a little bit about today, and less duplication, which is best practice in terms of improving quality of care into the future. It will be affordable not only to build it, but to be able to operate it in the future. And that is something that the current model that we're doing today hasn't been doing for a long time. And if we continue with it, we will have operational challenges in the future. And the last thing that we're pleased with this model and what we heard from the community, which was very nice, that our community is very worried about health human resource staffing issues today. And we were encouraged to take a look at models, make sure that we were building for a sustainable health human resources into the future. So I'm going to take a few moments about what today's model is in terms of big risks if we go forward with today's model into the future. There is likely going to be project planning delays if we continue to have to expand ourselves. We're willing to continue consultation and look for solutions. We have been all the way through this process. However, the risk to that is that future construction costs could be higher because every year that we delay this project is another year of costs added to the project. The other, to be completely transparent on all of these, there's a likelihood we could lose our place in the provincial redevelopment queue. There's currently about 6 hospitals, all within about the same amount of budget, about $1 billion, that have come in higher. And everybody is trying to go back and figure out what they can do. And, although we've had great support from our funders at Capital Branch and the ministry for the planning grant, there is a lot of folks that are waiting to be able to get their project moving along. If we put this model that we're doing now out into the future, I truly believe that there's a risk of closure without this change. 2 small hospitals as part of a medium-sized hospital system is at risk of closure without this change. And again, I think this is to be completely transparent, people need to know this risk. We will just continue to be over capacity and overcrowding because, right now we're in that situation, and the longer we wait to redevelop these hospitals, the longer we will continue to have the capacity and crowding issues. I mentioned earlier when I introduced Tim about our aging buildings are deteriorating. We have limited sprinkler systems. We have lack of fire separation in some of our buildings. And the longer we wait, the more these two hospital sites will deteriorate. And I guess the last risk is no new hospitals at all. I think that, if we continue to delay and the longer it goes, there may be, the project itself may just be pushed off to the side. So let's talk about what the new model is, Made in Muskoka Healthcare System. Again, it's the sum of one hospital with two campuses, both sites being designated as acute care. The Bracebridge site, I'm going to go into a bit detail about the predominantly inpatient services. So Bracebridge is predominantly going to be ambulatory, and Huntsville will be predominantly acute care. And I'm going to go into more detail on that. But the important piece of this future healthcare system is how we can build the two hospitals so that we're really enhancing community outreach. Both hospitals, acute care hospitals, will have 24/7 emergency departments with full diagnostic services. So where you're going today for your emergency care will be no different than what you'll be doing in 10 years. As I said, the inpatient beds to support the areas of focus of both our campuses will be explained shortly. Next slide. So let's talk a little bit about Bracebridge Acute Care site. And these couple next slides are actually made available now on our website, so people have a sense of numbers and services. So Bracebridge Acute Care will be growing, as you can see, in terms of square footage. The beds that you'll be seeing from today to the future may look to people like they're shrinking, but they're actually the number of beds we need to provide service to less complex medical surgical patients that come in through our emergency department, or also that would need short stay through our ambulatory day surgery program. And in fact, when we were looking at these numbers carefully, we just didn't pick the number out of the air, as you can expect. We looked at the number of patients that currently come through the emergency department at Bracebridge. We also took a close look at the type of patients in surgery. And the numbers that were actually put to us were less than this. And we wanted to ensure, again, we've got a long runway here. 18 beds gives us a flexibility. So if there's some patients that need to stay a little bit longer than 72 hours, but they're not complex, they just need an extra day or so, we will be able to manage that. I also want to say that not only part of the 18 beds include 4 beds that are level 2 ICU, and those beds are the same level of ICU that we have today in both of our organizations. Level 2 ICU is an ICU that can look after people who need a little bit of advanced respiratory support. Again, not overly complex, usually need a few days of ventilator support if necessary. So that's the level of care in our ICUs that we're doing today. Really exciting, the bottom. I mean, this, in terms of our overcrowding in our emergency departments, moving from 11 beds to 27 beds. And our visits are going up about 2,000 at Bracebridge. So again, the ability to have emergency rooms growing like that. Plus, we've got some really neat redesign that we're going to be able to do in our emergency departments, both of them, related to mental health services and an area that we call fast track. And if you visited hospitals in other jurisdictions, they have fast track areas where if you come in with a minor injury or illness, you can be fast tracked to another area of the emergency department, very rapid assessment and treatment, and you're on your way, leaving the core of the emergency department for the sickest patients. Next slide. So Huntsville acute care, growing in square footage. It's for the larger size and the number of complex patient needs specialized for inpatient care. And as you can see, when you move over to the right side, this future state for Huntsville acute care are for complex patients, patients that need a longer length of stay, and what I refer to as wraparound care during their acute and post-acute stay. We've referred to the one unit as reactivation. This is a unit that has, a real focus on once you've finished your acute care or close to it, we want to get people that are, back to their state before they came to hospital. You're going to see that these units likely be focused on those with complex issues, but also folks that are more senior and need to be reactivated. Our acute rehab will also service people who need medical, surgical, acute rehab that you see in some other hospitals. We've just been given that designation, so that's exciting for 14 beds. Acute rehab is also a requirement to be a designated stroke center, and Muskoka Algonquin is designated as that, and geographically was chosen in Huntsville because of the distance between the next stroke designated hospital in the south and to the north of us. ICU, again, another exciting opportunity and service for our Muskoka and area. Level 3 ICU will be the focus in Huntsville. A level 3 ICU we currently don't have in Muskoka Algonquin Healthcare. Those patients are people who require a higher level of ICU care, very complex. And currently now, those type of patients are transferred out of our region and go south to either Orillia, Barrie, and even at times, as we saw during COVID, people needing this level of ICU care could be anywhere in the province of Ontario, wherever there was an available bed. So this is an exciting advancement for Muskoka. When you think about when you or a loved one is at the most sickest time of their life, and they have to be transferred out of region for this type of service, these patients can stay in our area. Obstetrics will also is a specialized service that will be single-sited at the Huntsville site. The concentration of this critical mass is important for ensuring quality and safety of obstetrical care, and also to ensure the sustainability of staffing. The stats today, at the end of January, we have projected that we will do 267 births this year. Our future state for births is about 300. Currently today, today, if we project out, we will this year be doing 180 of those births at Huntsville and 87 in Bracebridge. Again, this has been kind of a historical trend. On a frequent basis, because of staffing, we aren't able to staff both obstetrical units. And even today, we went on single siting to Huntsville because we didn't have staff. When I say that we feel that this will improve the sustainability in the future for staffing, I think if you can put yourself into the shoes of folks that train in a specialty area, you want to do the work that you were trained for. You want to do it to the full scope of practice. Currently, our obstetrical nurses are only looking after obstetrical patients 20% of the time. The rest of the time, they're looking after general ward type of patients. So what we're seeing is, as fast as we get nurses in, and we've taken opportunity to train nurses new to obstetrics, they love it so much that they want to do more of it. And that's not what we offer today, but in this new model is what they'll be able to do for the most part of their assignment. Next slide. So Bracebridge future state compared to today, again, the focus of concentrating ambulatory and day surgery patients. You see the numbers there and the different services what we're doing today will translate over into future state. If you add up those three blocks, Bracebridge Ambulatory Care Campus will be up to over 140,000 visits compared to today at 60,000. We've got opportunity here, and I'll restate it again later, around expanding some of these surgeries. The numbers here don't even include the expansion of those surgeries like orthopedic joint replacements. In both of our sites, what we don't have today is the ability to have on-call emergency surgeries. Currently now, our general surgery is only on call at one site and has to respond to calls from both sites. Given that we know that there's emergency surgeries that we might be faced with and that come into our emergency department, this was one of the things that we wanted to change for the future so that we could have on-call for emergency surgeries such as C-sections. Next slide. So Huntsville services in terms of ambulatory and outpatient, it will look different as well. They will still have some diagnostic imaging procedures, obviously, to support their emergency department. The MRI is situated and planned for and going to be here in less than a year in Huntsville. And the main reason for the siting of our MRI in Huntsville is because of our designated stroke program. Again, another requirement of being a regional stroke hospital. And in terms of surgeries and procedure visits, again, you see the numbers in terms of we don't do that many inpatient surgeries anyways. Most inpatient surgeries, 85–90% are on an outpatient basis, but we do have some. And again, these are usually people that need longer length of stay. They probably will require some rehab or reactivation. So the inpatient surgery will be done there as well. Not to say that the surgeries that we do at Bracebridge, if they need some inpatient care, that we'll have the beds for that. And again, they will have the availability for on-call emergency services. So there is 2 rooms, although they're going down in operating rooms because they're not going to be doing, we're shifting our volume of outpatients to Bracebridge. They're still required to have 2 operating rooms to support any emergency surgeries because of obstetrics being there, the ability to do C-sections, as well as the inpatient surgeries. Next slide. So I'm going to go over it again because it's so exciting to think about what is new and expanded in the model of the future. Shared the emergency departments, the fast track, the improved mental health, outpatient surgery opportunities. Had the opportunity to talk to a colleague who leads the orthopedic program at OSMH, and also his team comes up to do minor orthopedic surgery already. He was very excited about hearing the opportunity about expanding outpatient orthopedic surgeries like joint replacements. Who knew 10 years ago that those patients who need their knee or hip replaced would not need a hospital stay? Now you come in at 6 o'clock in the morning and you're going home at 6 o'clock at night. He was also excited at the opportunity around some orthopedic trauma care that we haven't been able to expand at MAC as well. And as a result, going for some minor surgery at our OSMH could be shifted to the Bracebridge Ambulatory Care Center. And lots of other services that probably we don't even know today what the art of the possible is when it comes to technology and procedures that, quite frankly, I would say that some things we're doing in the hospital, people are going to be doing in their home if they're not already doing it now. And we know that there's a lot of things with virtual care that we're already seeing being transformed into people's homes. Our focus on making sure we're using our operating rooms efficiently. We do right now, because we don't have the space, we tend to use our operating rooms for certain things that could be done in a procedure room. More efficient use of resources and certainly a better patient experience. I also want to say, when I'm talking about the outpatient surgery opportunities, for folks to think about what's been in the media the last few months about private surgical centers. And we know, especially in our smaller communities, that if somebody does get a license to open a private outpatient surgery center, they call them, really does put us at risk. We know where staff will go to work Monday to Friday. It's just been known. The hospitals have spoken up about this, and I won't get into the reasons why. I think there's huge wait times, and the government's trying to respond to it. And quite frankly, many of us don't have the capacity sometimes to do that expansion. And so government has reached out with this model. In this model that we're providing you today, we really reduce our risk to that. This is a service that we can expand on through the public system. Next slide. Really, again, we're not losing anything. We've got diagnostic services in our hospital. We have opportunity to expand those services in the future. We're already providing diagnostic services up in Berks Falls. Lots of opportunity to do more of that in the future if we have a concentrated focus on diagnostic and ambulatory care. We know that mammography services are increasing because of increased screening. A vision that we've been talking about is, with everything concentrated related to women's health, you have your mammogram, you have your bone density, and there's a lot of areas that we're not touching on in terms of women's health, menopause, cardiac disease, etc. Again, having everything in one spot, there could be clinics that would be highly effective for women's health. We've talked about the MRI. Another area that we really want to advance in our new hospital is our Indigenous healing practices to support our 2 First Nations community. And we have a long way to go in that. And certainly some of this has already started today. But as we looked at redeveloping these 2 hospital campuses, a lot of attention's gone into where we can provide safe space for our Indigenous communities and other diversities as they come along, and we need to change. Virtual care is going to be integrated in all areas of the hospital, and I'm pretty sure everybody has felt the impact of enhancing virtual care during COVID. The fact that we'll have virtual care in every patient room, every area of the hospital, really provides us opportunities that we can use virtual care not only between our own 2 acute care facilities, but with other hospitals in our region, with our community partners, and our health hubs. So there's a lot of opportunity and advancement that we can do with virtual care. We also have talked a lot about mental health and wellness and rehab services. Again, things that people don't have to come to hospital for, but if we have partnerships in the community and we can do outreach, these are the two areas that we've thought about how important it will be to expand those. Next slide. So again, at the end of the day, I'll say it again, we're not losing anything. Are things going to look different? Absolutely. We are being given 34 more inpatient beds. We're going to have a level 3 intensive care closer to home. We're going to have acute rehab, reactivation. The reactivation, again, we really feel confident that it's going to have an impact on patients who are waiting for other levels of care, like long-term care, retirement home, group home. In our planning assumptions, we're currently sitting at about 30% ALC. In this model that we're proposing, we are looking and been targeted to target about 20%. So we have had to look at our care delivery model today and what we could do differently in the future to try to prevent people in the first place becoming alternate level of care. And if people don't have these wraparound services with their complex needs and longer length of stay, there quite possibly will become ALC. So our model is one to address that. One of the key benefits, I mentioned it with obstetrics, but with any of the areas that we've put a focus on these units with patient groups with like diagnosis and care needs, with the right staffing complement, people are having great staff satisfaction because they're looking after the patients they want to. They have team members that have diverse experience, but they have a focus on the care that they're providing. And we also believe in terms of recruitment of specialty staff and physicians, this model will have an impact. We've heard from many of our physicians across Muskoka Algonquin Healthcare that more and more newer physicians that are coming out are looking for opportunities to focus on primary care. With this model, it doesn't mean that they can't do hospital care. But there are a number that want to just do their practice. And I have to say, quite frankly, good healthcare starts with primary care. So for those physicians that want to stay in their community and do primary care, this model definitely will allow for it. And if there's physicians that want to come into our community and just do emergency care or emergency and a family practice, this model also can address that for them. And all in all, this model, there's a lot of research in terms of centers of excellence, centers of focus, whatever the buzzword is. But there's definitely evidence that it has enhances the quality of patient care. Next slide. So there is a lot of work ahead of us. I cannot underscore that. This is a new model, focus centers of care, system-based. All of those things we aren't necessarily doing today. And that is going to require us to work with our teams, look at our medical coverage, our staffing models. We've also heard, the concern about transportation, especially if people in hospital a bit longer and having to travel. I'd urge you to think about, though, that the ability to travel a little bit further, but know that your loved one is getting a level of care that's comprehensive, that can get them home sooner. Maybe the drive is, a bit longer, and we're going to do everything we can to take a look at what we can do to address those needs. But in the long run, they're going to get enhanced care and be back home sooner. The other area that we know is going to be work ahead of us for the next few years is continuing to build and enhance community partnerships and investing with those community partnerships so that we can do more care in our communities outside the walls of our hospital. And we've got some, as I said earlier, we've got some really great examples of how we've been doing that already with our Muskoka and area Ontario Health team. And this model just opens up so many more doors for us. I, again, will underscore that there is work ahead of us. Change is hard. It's hard for all of us. And we just need to remember that what we're going to be doing years from now needs to change from today. So next steps, community and stakeholder engagement. We've got 2 more focused events coming up. We've got other stakeholders who want to have more discussion with us, including the physicians. So we have a discussion with the Credentialed Staff Association. We have 123 physicians that are credentialed with Muskoka Algonquin Healthcare. And, there are some that are seeing this for what it can be, others who have a lot of questions, and we want to work with them on trying to answer those questions over the next few weeks. If we stick to our schedule and, be able to answer the questions and get people's buy-in into this new model, I guess I'll call it, we would be looking at having our board approval for the site selection, local share, and functional programming in March or April, submitting to the ministry in the spring, and that will keep us on target with our timelines, which is the next slide. So this is their approach. We know that we are on Infrastructure Ontario's schedule, which means that we now have dates to stick to. The functional programming, if it goes in, as we stated, we will definitely, regardless of the model, we'll have lots of back and forth depending on the model, maybe more than we expect. And then if that gets approved, we move in 2026, we move into detailed planning. And again, you can see the stages that are there. There's still a lot of planning ahead of us in this schedule if we stay on track. And those red dots are where we have to check in with our cost consultants every juncture to test and see where we're at from a budget perspective. By 2027 on this plan, we will be able to go out to tender. That process takes 18 months to 2 years, where we can then award a construction contract, and shovels will be in the ground in 2029. Next slide. Local share financing plan. Many of you have heard this before, but just so that people are reminded that our communities are responsible for 10% of eligible construction costs. And we're also responsible for 100% of the costs associated with hospital equipment, furniture, any land that we have to purchase. Some folks don't know that we've always had to be responsible for the costs associated with equipment and furniture in the hospital. And that's why we truly love our foundations for sure, because they're the ones that do the majority of the fundraising, along with our auxiliary for those yearly replacements of equipment. When we say the local share, who makes up the local share? Quickly, Muskoka Algonquin Healthcare, we're part of that. Any assets we have at the time of move-in are assets that we don't have to purchase. So we try really hard to see what we'll be able to have in 10 years that we can move over into the new buildings. We also have some land that can be that we're going to be selling. There is the Bracebridge site, and once we're ready to leave that building, we're going to be able to put that on the market and get revenue from that. We also own a building in Huntsville that's the long-term care facility, and we'll also, once they have moved, that will be eligible for revenue as well. Our two wonderful foundations who work, as I say, hard every year, will be working even harder for their local share contribution, and the work is underway to plan for what that capital campaign will look like. The District of Muskoka, our municipalities are also contributing to local share, including communities that are outside of Muskoka. So Almaguin is also contributing to our local share. Next slide. As a reminder to folks that we needed to buy property. So the new Bracebridge site will be on 300 Pine Street. Not all of the criteria, but a good chunk of the criteria that we used in that process to assess our final choice. Huntsville will be on the same piece of property because we had lots of acreage. So we will be using the property. We didn't have to purchase a new property for the Huntsville site. Next slide. So I started this presentation with the fact that this is not just about building 2 hospitals. In fact, I hope I've shown you that it goes well beyond 2 hospitals. We have a model that is looking to the future. What we're doing today isn't sustainable. So the future model is innovative. It will provide us with new and enhanced services. It's got a great ability for future sustainability of staffing and for community integration. I was asked at one of the sessions whether or not I honestly believe that this model will work. And my answer is absolutely yes. Like others, I went into healthcare to make a difference. regardless of whether I was a nurse, a CEO, or otherwise. And I believe that this is the model that will take Muskoka into the future for their healthcare system. Thank you.
Thanks, Cheryl. And we're ready to start the Q&A session. I want to thank everybody for putting their questions into the Q&A. I'm going to do my best to collate and read these aloud as we work through a number. I'm going to start with a couple that are relatively simple. A couple have asked about this video being recorded and us making it available later. I can assure you that it will be on the Muskoka Algonquin Healthcare website. We will be using YouTube to house this video, and everybody who's registered for a session will receive an email when that's occurred. As well, the slide deck, we've had a question around a change in a couple of the slides. For those of you who are so keen to come to other sessions earlier in the week, just want to let people know that we've been very open to feedback from our communities who have been emailing us at the redevelopment email, giving us some suggestions, and we've been trying to make sure that we put as much information as we can on the slides for you. And so that's a reason why those have changed. So both the slides and the recording of this meeting will be available. There was a quick question around the helipads at both sites with respect to supporting emergency care. And yes, part of the plan is to have helipads at both hospital campuses. There was another question that I think I can answer safely around chemotherapy. With it moving from Huntsville, it would be at the South Muskoka campus in Bracebridge. And so that was on the slide around a projected 11,000 chemotherapy visits that would then in the future occur at the Bracebridge campus.
Allison, I
Yes.
just want to chime in. This is an area, as we probably, if you've lived with cancer or anybody that you've loved, again, the advancements are changing. And so right now, the way that and the numbers that we're seeing, we do believe we can provide at one center. We will be in constant discussions with our regional cancer program, and feel that if things do change a little bit, we will have the flexibility if this is something that may need to either expand at Bracebridge or perhaps even expand at another site. So it's something that it's a bit of a moving target at times because of the advancements in cancer care. So just so folks know that, but that number will definitely, as a critical mass, be fine for being one-sided at this point.
Thanks, Cheryl. Just going back to the Q&A, maybe Alistair can take this one regarding contingency and inflation, and has there been some oversight in including contingency and inflation in the original building plan?
Thank you for that question, whoever asked it. The issues of both inflation and cost projections are done through a formal consulting company that has experience specifically in healthcare sector work. As a result of COVID and construction logistics, the cost being bid on projects has gone up far more than those original project estimates were. I think, as Cheryl had indicated, the project budget with Infrastructure Ontario was actually set in 2022, and this was based on previously done projects in the province. Major healthcare projects have seen increases of up to 60% in the last 12 to 14 months from the original estimates. And part of this is caused by the fact there are very few construction companies in the province who are eligible to take on large healthcare infrastructure projects, and that will drive up the cost as well. So the original question, have those been factored in? Yes, they have.
Thanks, Alistair. Given the population of your service area is heavily concentrated in the south, would why would the two hospitals not be reversed? Namely, why couldn't the inpatient facility be located in Bracebridge? Cheryl, do you want to remind us about the stroke center?
Yeah. Thank you. I was trying to find my clicker there. Yeah, so it's really based the start of when we started to look at this model was taking a look at where some of our services absolutely had to be for stroke. So as a regional stroke center, and the geography of that, as I explained, between north and south, and Huntsville was chosen for that, you start to get services that need to be wrapped around it. So rehab, acute rehab, ICU care. And so we started with that, and then with the notion of what other types of services that we could utilize our rehab staff for. That's how we led to looking at reactivation. And again, trying to split those beds between the medical beds between the two sites isn't as simple as just taking beds and putting them in each site. The type of care we're talking about needs specialized rehab services. The concentration and critical mass makes a difference in a hospital our size. And the minute you start dividing it, you can't have small teams going across two sites. So that is, that's a big piece of the rationale that was there. And I don't know if anybody else wants to add to it. It's the type of services in these beds.
Yeah, I think the geography was a major driver for where the location of Huntsville is, and if you think about the catchment being much farther north than just the town of Huntsville, and some of the other drivers were some of our volumes for the obstetric services. Currently, 2/3 of our deliveries happen at the Huntsville site, so we needed to look at adjacencies for all of those programs, and that was part of the decision making.
Another question from the Q&A. If people in the community don't agree with the proposal, are we likely to lose the $967 million funding to another community's project?
It is definitely a risk. As I said, there's a number of hospitals. There isn't one hospital redevelopment project that has come in on budget. I know of a couple of folks that are waiting for their planning grants. And if they've been doing their homework, as most hospitals have been doing in terms of the future of healthcare delivery, and they come up with an innovative model and they can make it fit into their budget, and they do the planning to it, it's possible. To lose it all, again, if it's the will of folks to continue on with looking at other solutions, the risk of delaying this project and all of those other risks that I talked about earlier are very real. So would we be taken right off? Probably not, but our delay will definitely be pushed aside if the will of the community is to continue to look at other options.
There was a question around where dialysis would be sited, and that would continue at the Huntsville site. There's also another question regarding pediatrics. Melissa, can you tackle how we might be addressing pediatrics in the future?
Yeah, so currently we have not planned for pediatric inpatient beds. However, our pediatric volumes that we see in Emerge every year have been steadily increasing. So that's definitely, that will definitely be a focus within our emergency departments. In 21-22, we saw 7,000 pediatrics across both of our sites, and we rose to 9,000 in 2023. And part of that was due to the respiratory surge that we all saw, I'm sure, if anybody has kids in daycare. We currently do some very short overnight stay pediatric work, and that's typically our population of children who may require an appendectomy, and they stay overnight, and that's about 20 a year. So really, really, really small volumes at this point.
Thanks, Melissa. A couple questions around the 2 versus 1. Why did the ministry demand 2 hospitals instead of 1 when we can all recognize there are considerably more costs to building 2 than there is to 1? And would the 1 site model be reconsidered is a similar question being posed.
I'm going to hand that over to Maureen because she lived through those that experience as the board.
Thanks, Cheryl. If you recall, previously in the development of the new hospitals model in Muskoka, the previous board of directors had moved forward with a 1-site model that was intended to be centrally located with appropriate drive times. That was not an acceptable solution for either the North Muskoka community nor the South Muskoka community, and was fundamentally rejected by all. It was felt that there needed to be 2 hospitals in Muskoka, 2 facilities of the same corporation, and the one site model was abandoned in 2016 when the plans were resubmitted to the ministry for the model that we're looking at now, 1 corporation with 2 campuses in 2019. That was at the advice and direction of the ministry that we explore a 2-site model again. The 1-site model has come back for discussion, and I think we have already discussed that at length in our communities, and that's not an acceptable solution for anybody in the community. So that's where that was left, and that's why we're on this track and why the ministry has recommended a 2-site model for us to continue to explore. Back to you, Alison.
Thanks, Maureen. There were a number of comments in the Q&A regarding physician recruitment and physician attraction, and some commentary about some of the physicians who are currently not supporting this model. Dr. Abdul Razak, can you speak to some local doctors that may be in favor of the plan, and why we haven't heard from them, and how we're going to continue conversations with the physicians regarding their concerns?
Thank you for the question. A very valid question, especially with the discussions around this inside the hospital and in the community. I would just like to comment that we have had an extensive internal process in designing this model that include multiple rounds of user group meetings, and a total of approximately 250 professionals were included, physicians and nurses and midwives and support staff and patients and family representatives. Out of our physicians, 1 out of every 3 physicians was invited, and a total of 1 out of every 4 physicians was included in the user groups. And many physicians are in support of the model. We know that there is a group who have voiced concerns primarily with practices in the Bracebridge area. We will continue to engage and discuss and improve the model to make the best in terms of available resources, while keeping in mind the need for functional efficiency and the need to address health human resources. Some of the concerns stem from viewing care or service in the form of silos rather than a system, and we truly need to move towards a system-based care. Some of the concerns are based on viewing the 2 hospitals as 2 independent facilities, where these are 2 campuses of 1 organization and truly do complement each other. If we look at each site separately and independently, then both sites would not be adequate. But together, they are much better than what we have now. We also know that the newer model will need newer models of care, and change is not easy, and there will be a lot of change management required. And this is something that we will work with our colleagues on. And lastly, we have a total of approximately 220 physicians, 120 physicians who are either active or switch staff, and 100 physicians who are locums or regional affiliates who provide very regular care at our hospitals as well. Credential Staff Association represents all these physicians. The representatives, the president, the vice president of the Credential Staff Association are members of the board and of the medical advisory committee and have been informed throughout. We have had a special engagement session with the Credential Staff Association, and we will have one more session with the credential staff, which includes the physicians and the midwives, that by definition the credential staff, on February 20th. So the dialogue continues. In terms of recruitment and retention, we know that there is a lot of competition for talent. Physicians, nurses, midwives, respiratory technologists, radiation technologists, radiology technologists, all across the board. There is a lot of competition across Ontario. Having newer state-of-the-art facilities within a system that works closely with the community partners and the Ontario Health Team will be a truly drawing factor for recruitment and retention of staff once we establish the newer models. Thank you.
Thank you. I'm going to read a bit of a scenario question and ask Lindsay from Surgical Services if she could comment on this. What happens if during ambulatory surgery I have a major complication which requires longer care and treatment beyond what can be, and this is in Bracebridge, but not requiring an ICU? Would I be transferred to Huntsville?
That's a great question. The goal would be that your surgery, you would stay at the site that you're at. We do have a plan that most of our patients would require an average of 72 hours in our inpatient unit in Bracebridge. You know, if you did require more complex care after that time, you would be assessed. You would be assessed by your clinical team, by your surgeon, and a decision would be made regarding what the best plan of care for you would be at that time, whether it be transferred up to Huntsville or whether or not you just need an extra day or two in South Muskoka in our inpatient unit.
And Lindsay, while we've got you, maybe you could answer the question to explain a procedure room.
So a minor procedure room is not an OR, but has everything we would need to perform minor procedures, minor surgery. So those procedures could be anything from the skin lesions, those skin cancers that you get removed, to vasectomies, cataract surgery. There's a lot of procedures now that are moving outside of the major operating rooms and are being done in a minor procedure room that is well equipped to do those procedures, but saves the operating room for those larger cases.
Question regarding how hospital equipment is purchased and why is that not covered by the government, unlike in the education system?
You know, you
I
hate
can
to
field
say
that if you'd like, Allison.
Okay, go ahead. Sorry.
That's been the way it has always been in healthcare. The government is not responsible for capital equipment purchases or replacement, which is why hospitals are entirely dependent on their foundations for raising funds to acquire that. That's nothing new, and there's no indication that the government is going to get shy away from that current practice.
Thanks, Alistair. A couple questions regarding the community component of care and how much money or how is money going to be allotted to go back into each community to cover community care such as PSW support, and knowing that there are challenges in the PSW, I think in all healthcare worker designations, whether you're in a hospital or otherwise. How is this going to work?
I don't think we have all the answers, but I would like to turn it over to Katie, as she's doing a lot of work with our Ontario Health Team, and she can describe a few things we're doing today that likely will expand into the future, and how that funding works now will likely be where we'll continue to go. But Katie, would you mind fielding that?
Yeah, for sure. So right now we are working with the Ontario Health Team to look at different models of delivery of care in the community. Muskoka and Area Ontario Health Team has invested significant time and resources into collaborating with some of our community partners. We have our hospital to home program about providing wraparound care to, I think there's been some concerns about how are we pushing people out into the community, and that's never our goal. Isn't to push people out into the community unsafely. It's to provide those wraparound services so that when people are going home, they're going home safely and they're going home successfully. And also partnering with our Ontario Health team to provide other options, like looking at new ways of delivering care in the community, like neighborhood models of care that they're trialing in other regions, and we're just starting to roll those out now as well. So we're doing a lot of work, and that's going to be the future of healthcare, and that's other countries and other provinces are looking to do those as well. And I think that's going to make a big difference in the way we see healthcare in the future. It's not going to be inpatient beds that we see healthcare. It's going to be in the community. It's going to be ambulatory care. Right now we're seeing inpatient beds because that's what we've lived for the past 20, 30, 40 years. But the future of healthcare is going to be in the community, in the home, virtual care. It's going to be a big shift in thinking and imagining, but that's what it's going to be.
And Katie, maybe while we have you, we could get on the topic of obstetrics. There are some questions regarding how people will potentially migrate to Orillia from Bracebridge. How will Bracebridge be able to provide emergency obstetrical services? What could a patient's journey, a pregnant mother's journey, look like if that care is concentrated in Huntsville?
So I think, again, visioning a planned delivery in Huntsville is very different than visioning a unplanned delivery in Huntsville. Right now we have patients that are planning to deliver in Bracebridge, and if they arrive in Bracebridge and aren't getting the care there, then they're transferred, and that's a very different situation than planning a delivery in Huntsville, where they know where they're getting care. They have had a relationship with that hospital, and they've planned how they're getting there. I know we'll be working with our stakeholders like EMS and transportation to ensure our patients will be able to know how to access care when they need it. In terms of repatriating patients from the southern regions to Huntsville, I know there's concerns that we're not going to have Bracebridge and Gravenhurst patients delivering in Huntsville. Our data shows that we already do. There will always be level 1 appropriate patients who choose to deliver in a level 2 center. And at MAHC, we're very supportive of the PCMCH guidelines of level of care, including shared decision making. Making shared decisions includes ensuring patients have all the information that they need to make a fully informed decision. And that includes what services are available at each level of care. And people will continue to make decisions that are right for them and their circumstances. And those decisions will continue to include wanting to deliver in Muskoka, wanting to deliver at a MAHC facility, and wanting to deliver at a level 1 center where low-risk patients are very appropriate to do so. MAHC is fully supported and integrated into our regional network. And we're also very connected with our local level 2s like Orillia for support.
Allison, I just want to jump in there and add to Katie's great comments. One of the things Katie referred to was PCMCH, and sorry, we get hung up on our acronyms, but it's the Provincial Council of Maternal and Child Health. This is where best practices come from, and that is the type of evidence that we're using to plan this hospital and the two-sided focused concentration. So as Katie said, there are specific things for a level 1, level 2, but there's a lot of other best practices out there that have influenced why we're moving to this model. So thanks, Katie, for highlighting that with that group. Thanks.
Going to add, there was a piece of the question that had asked about the journey of care. So there's also the part about the prenatal journey, which is typically handled in the communities by the family physicians up to a certain period of gestation, so up to a certain amount of weeks. When a woman is pregnant, and that process would continue within our communities with our family doctors. So you would have your prenatal care up until it's time to meet your person who's going to deliver, and at that point, that relationship would change over.
Thanks to all of you. A quick question I think I can knock off is with respect to the names of the healthcare consultants and architects that we've been working with. And I mean, we've been working with these guys for many years. The programming side of things is Resource Planning Group, and they are expert in healthcare programming. They've worked on a lot of hospital projects in Ontario, not just ours. And the architecture firm is called Stantec Architecture, and they too specialize in healthcare construction and design. And so they've been part of our team, actually dating back to the early days of planning. I'm going to pose this question to Maureen, who not only is board chair, but also the chair of the local share committee, and wondering if we will be returning to district council now that there's a different model of care being proposed with respect to the contribution that the district has set aside for local share at 77 million.
Thanks, Allison. The local share committee, which is a group of the group that has been managing and looking at the local share contributions, has been in progress since 2016. I am a founding member of that committee. I have been on it from the beginning. The local share committee's work is not finished. We continue to meet to discuss how we will raise and pull together the $225 million. We are at this point in time $10 million short. And so the work of the local share committee continues. The discussion around the new model and how local share builds into that or doesn't build into that is a conversation that will take place very soon in the future. The local share committee met in December. We're apprised of a number of the changes that were being considered, and so they have been kept up to speed, and we will be meeting again to discuss that further. District Council has made a decision. I believe that if the local share committee was to move ahead and make a change or make a proposal, that the district council would consider that. On the local share committee are the mayors of all of the district municipalities in Muskoka, as well as the district chair, the boards of both foundations and their CEOs are also on the committee, as well as Cheryl, Dave Offelman, and myself. So that committee has met regularly and will continue to meet until the local share solution is completed.
Thanks, Maureen. A question regarding mental health rooms in the emergency department. Many would love a mental health room for a timeout. Do those rooms mentioned here have that function, or are other facilities upcoming?
I would say at this point, I mean, we know we need to enhance them. We know that the ones we have now have been put together with space that we've, basically just found and for something. And so certainly not state-of-the-art mental health safe rooms. And that will happen once we get into the design phase. Of course, we'll be involving partners from Canadian Mental Health and others with what's, new and improved out there at that point of design.
Some questions around attracting staff. How will this model recruit new professionals? Maybe Mary, you want to take that one, and there's a little more specifics too, maybe for the chief of staff regarding how we might be able to attract family physicians to locate south of Bracebridge, for example, in Gravenhurst.
Thanks, Allison. I'm really happy to answer this question. Dr. Abdulrazik referred to the fact that a brand new hospital, 2 brand new hospitals are going to be a magnet opportunity for us. And we will be brand new hospitals, in the newest hospitals in the region. And what we know from other new hospital builds across Ontario and our consultation with them is it does become a magnet for talent. And of course, we are in a talent war, trying to attract the best talent. And so this will be a significant advantage for us in that talent war, no doubt about it. The design of our 2 hospitals and the models of care are going to offer something for everyone, depending on their life stage and their own personal requirements, to make sure that they achieve the balance between work and life that they want. So an ambulatory center may offer more flexibility with shifts that are suitable for families, and also very dependent on what individuals are looking for with respect to their experience, specialization, and their scope. So lots of opportunities and something for everyone to have many jobs within a career within our 2 campuses. So very exciting. We're very confident that we will be able to attract and retain the talent that we need to build these hospitals. And what's also exciting is we are seeing growth opportunities. So those would be my comments, and the fact that we all know that Muskoka is a wonderful place to live and to work. And we think it's the best region in Ontario. And so we think that we have a lot going for us, and we're looking forward to the challenge. Thanks for the question.
Thanks, Mary, and thanks, Alison, for the question. I will add a few comments from credential staff perspective. As mentioned, the distinction between, for primary care, the distinction between care in the community and in the hospital will facilitate recruitment of family physicians. The newer generations of family physicians are not always keen to provide all types of primary care in the community and in the hospital. Some will prefer to focus on primary care within the community, and some will want to focus on acute care in the hospitalist model. And so that distinction in our newer model will help attract the various types of interests for primary care. We have established an HHR task force under the umbrella of the Muskoka and Area Ontario Health Team, with participation from the hospital, the family health teams, and the various municipalities. It's quite active and moving forward well with HHR recruitment. We know that we need somewhere between 14 and 16 family physicians over the next 5 years. We know that we have between 4,000 and 5,000 individuals without family physicians, both in northern and in southern part of Muskoka. So that is certainly an area of focus. We also know that this is a province-wide concern, and that within a few years, 1 out of every 4 to 5 Ontarians will not have a primary care provider. So there is competition for talent, and establishing newer care models that are more adapted to the newer generation and having the new hospitals will certainly support that. Also, with specialized care at one site or the other, these centers of focus will be a true drawing factor for various types of specialist physicians as well. Thank you.
Thank you. A couple questions regarding this kind of model and whether it's been successful in other places.
I can take that, Alison. Thanks for the question. So this model has been implemented in Quinte Health, in which they have 3 different sites. Belleville General Hospital, which provides acute care services. Trenton Memorial Hospital, referred to as, first one referred to as Site A, the second one is referred to as Site B, provide emergency services and short inpatient stay. And a third campus, Site C, also similar population site to Muskoka, with population of similar demographics, and also they have a summer influx of visitors as well. The third site provides emergency services, long-term care, and outpatient services with diagnostic imaging. They also have a transportation services between all the three sites. And the model seemed to be working very, very well since 2015. Additionally, in Hamilton Health Sciences have two different sites that they provide patient transport, and also they provide a way to provide continuous care between the two sites, between the Juravinski Hospital as well as the McMaster University. Thank you.
People are asking about how feedback is going to influence any changes or enhancements to this model.
Well, I'll use if I'm repeating myself, I apologize, but our last set of user groups, it was made, a suggestion was made about the concern of not having ICU services for the Bracebridge campus to support the emergency department. We had great conversation with our consultants that day. The consultants spoke with the team members who were requesting it. We've taken a look at it and again been able to make that change that wasn't in the model previously. So that's like even current as we speak today. If there are other solutions that can still get us to a hospital of the future, and they're, we want to hear about them. So again, going back to the drawing board, or trying to do what we're doing today into the future, it's not sustainable. However, if there are tweaks that people say, could, we look at this, could we look at that? Similar to what, I talked about with chemotherapy, things might change as we go along. But the concept of having the two campuses with focus of care models around populations, is really what we're striving for. So if people have input into that, we will continue to listen and happy to hear the solutions. So I think that, the meeting on the 20th with the physicians, hopefully, they've been hearing the information. We've been trying to answer questions, coming back with them and any other groups that want to sit down and have a conversation around, other types of solutions. We'd be happy to hear it.
Cheryl, are staff in Bracebridge going to be expected to travel to Huntsville and or vice versa? Or will they not have a job? I think the transportation solution could very much work for staff as much as it could work for visitors and patients.
Yes. Yeah. And, in early conversations with the district, when we were talking about, we definitely have to look at transportation. The district, for many things other than healthcare, transportation is a challenge in Muskoka. So they've been looking at some creative opportunities there. We hire people to Muskoka Algonquin Healthcare. People often have a home site, that there's their home site, but many of our staff actually work between the two sites. So there's a mandate that you're joining the organization, and definitely just for staffing purposes and that type of thing, people kind of have a home base, so to speak. But if needed or desired for that matter, because some of these concentration of certain services will be a real exciting thing to staff, or I'm talking professionals, regulated health professionals that are maybe early in their clinical journey. And I can only think of a new nurse who's very excited and sees the future of ICU, being able to start in Bracebridge, work in a level 2 ICU, get some experience, and then at the end of the day, not have to leave Muskoka Algonquin Healthcare to go to a state-of-the-art level 3 ICU, they actually have the opportunity to transition within their own organization.
I was just going to add that I think I think there was a comment about people not having jobs. Both of the sites will be growing in size and growing in their services that they provide. So there will be more jobs. Might be different than what people are used to doing in their home site right now. But as people grow in their career, we're still talking 9 years out. So there will definitely be more jobs for our staff that work here now.
Questions regarding land and site selection for Bracebridge. Why didn't we take the land? I don't know that it was offered, but offered by Fenner Dunlop. Rationale for choosing the Fowler site, and some questions and comments about a statement from the Muskoka Royale property owners about a potential $10 million donation. Alistair?
I can certainly field that one. Thank you very much. So let's clarify a few things. You had a number of questions in that salvo. The first is, we originally did have the preferred site initially was the Muskoka Beach Road site. And then we undertook what is called due diligence exercises, which means we evaluate the geological, the hydrological, environmental, species at risk, all those sorts of things. And based on that and the road issues for building in and for access, we determined that the Pine Street site was the best site. And that's why we elected to have that. In regard to the question about was it free and a $10 million donation on the table, I'm the one that handled the negotiations for these with both owners. And I can tell you very clearly that at the point that we made the decision and that we went forward to the board, there was no free property available to us, and there was no specific amount of $10 million donation on the table. Not that that would have necessarily changed the outcome. The decision was based on the value of the land for the build of the hospital now and for the future, and for consideration of the issues that I said with all the due diligence work. So there's unfortunately misinformation out there in regard to that. And I can tell you that we went through our site selection committee, which went to the capital project steering committee and then to the board for its final decision. Both properties that we were looking at had a price tag to them.
Thanks, Alistair. And while we have you, if we go with this model and there's opportunity to expand services, will the buildings be able to handle this?
So not only are the sites able to handle it, but the building design will be set up by the architect such that expansion will be possible, both in terms of, it's at this point in time, we're only dealing with block schematics, which means very rough floor plates, but we have potential with the architects to have expansion to the floor plate or the footprint of the site, as well as potentially going vertically. But that will be built into the capacity of the building to accommodate that.
Questions regarding auxiliary volunteers. Will there be more or less need for volunteers? What will happen with them?
I'm happy to answer that question. As we've already discussed about the growth with our staff, we will also need to grow our volunteer base at both of our hospitals. When you think about the number of patient visits, as an example, at the Bracebridge site, which is going to increase quite exponentially, there's many opportunities for us to expand our volunteer services, and we're so grateful for their support so far, and looking forward to seeing that support continue to grow in our communities.
There's another scenario question. Maybe Dr. Abdelrazak can handle this one. When a South Muskoka patient requires long-term in-hospital care, does the care continue with the patient's current doctor, or does a North Muskoka doctor provide this care?
Thank you for the question. Valid question as well. Let's say the patient journey starts in the South Muskoka site because the type of services offered at that hospital site. As Lindsay mentioned earlier, after a few days of admission, there is a clinical assessment at what further care is needed. If the further care is available at the Bracebush site and the patient needs to be there for 2 or 3 more days, that is where the care will happen. But if the additional care requires a higher level of ICU or a type of reactivation or rehabilitation services, then the more specialized service will be at the Huntsville site. And for that type of specialized additional care, the patient would receive the care in Huntsville. I would like to clarify to our audience that the majority of the patients who are admitted in the hospital are under what's called the hospitalist physician. Currently, 80% of patients admitted to Muskoka Algonquin Healthcare are under a hospitalist physician, and only 20 to 25% at most are under their own family physician. The model of the future, and this is happening across Ontario, is towards a hospitalist model. And so the patient will receive the care in the community with the primary care provider. In the hospital would be under a hospitalist, whether the hospitalist is in Bracebush or in Huntsville. And then the specialists would provide the care depending on the individual patient need. Now, as with all groups of professional staff, the credentialed staff, physicians, primary care, hospitalists, and specialists will have a primary site, but they will provide care at the other side as well. Our credentialed staff have credentials at Muskoka Algonquin Healthcare. It's not site specific, and as such, the care can be provided by the same physician at both sites. Usually we'll have a primary site, but the physician will be providing care at the other side as well. That is what is currently happening, and that is not to mention our regional affiliate staff who work primarily, let's say, out of Aurelia, North Bay, Barrie, and some from the GTA, and they do come up and provide service at Bracebush and in Huntsville. Thank you.
More questions just regarding the potential transportation model. Women who would be going to Bracebridge for mammography and or bone density, could this transportation be free? Other questions around who would operate this, a little more of the vision maybe per se of what that could look like. And I think there really is a difference between a patient transfer that's acute versus something for, heading down the highway and back, vice versa for a mammogram.
Yeah, I'll take that. We haven't got it ironed out by any means, but we have, certainly, again, reaching out and taking a look at what other multi-site organizations do. There is a difference, you're right, Allison, in terms of a shuttle service for patient's family or for patients that are going to a scheduled visit versus somebody that needs acute care transfer. And, there's lots of transfers we do today that we don't use EMS for. But we transfer people in and out of our region using a transportation system. So, and then we want to look at something to address those type of, coming for a scheduled visit, but you don't drive. We've heard things like a shuttle system. If, again, I think there's loads of opportunities out there. And in terms of cost, I think, again, that everything's on the table. We want to ensure we're enhancing the patient and family's experience. So, honestly, I think I've heard people are all worried about what this transportation system is going to cost. Again, we'll look at something that's affordable, but I think we've got partners that we can work with so that we're all in it together to make sure people in Muskoka and area are getting around for healthcare and probably other things. So hope that answered the question.
Just another question regarding physician support and arguments that physicians will not want to stay or practice in a community with different hospital services than they are today. Dr. Abdurazik, anything more you can add around the physician concerns?
The physicians working with Muskoka Algonquin Healthcare will be working as part of the system, In Muskoka, that includes the two acute care hospitals, that includes the family health teams, and includes the Ontario Family Health Team. Some of the care that their patients will need will be provided in Bracebridge. Some of the care will be provided in Huntsville. It depends on the type of care and the patient community, the patient population. Patients who are admitted are under an MRP, or most responsible provider, or most responsible physician. That is the hospitalist model. And usually hospitalists will be on call 1 week at a time. The number of hospitalists would be equivalent to the amount of service that they provide with a specific on-call system. And for specialist physicians to provide the consultation and or the surgery or procedure, and that will happen whether it's in Bracebridge or in Huntsville. All in all, I see the newer facilities and the newer care model as drawing factors for physicians across Muskoka.
Thank you. And a couple questions regarding our foundations. Will they continue to operate separately? Will they work more collaboratively together? Sure, if anyone feels comfortable speaking to that.
Sure, I will. There's no discussion about amalgamation. I think our focus is all for all of us related to local share to work together. So between the local share group, and then in terms of working together, the two foundations, along with the hospital, and Dave Uffelman is on there from the board as well. We've striked up what we call a group to look at how do we kind of organize ourselves for a major campaign in the future. We're just in early stages of it, but they definitely are working very closely together with themselves and with the hospital. We want to make sure that we're providing consistent information and messaging out there. And it's very early days. Both Catherine and Leah reinforced that, they don't have the 35 million in the bank yet. And so we've got a long way to go, but really happy to see the partnership across the foundations in the hospital and with Dave as our board representative.
I'm just doing a time check here. We are at 8:45. Is the cost of the land, just trying to slide a couple more in here, is the cost of the land part of the full project cost of nearly 1 billion? And that would be the land that has to be purchased in Bracebridge, of course.
The answer is yes. It's
Thank you.
part of our local share.
And I'll just remind everyone that we will be posting a hard copy of this presentation on our website, as well as a video once it's completed later this week. I'd like to thank everybody for joining us today. We did receive more than 100 questions in the chat, the Q&A, that we will continue to be trying to address, looking to create a frequently asked questions that we can make everyone aware of and put on our website. So I do want to just take a moment to thank everybody for joining us tonight and wish you a good evening. Thank you.
Thank you, everybody.